Traumatic brain injury, TBI. So what is it? Well, it's when an outside external force impacts the head, and that external force causes damage to the brain. And so we have two different levels of effects when patients have traumatic brain injuries. The first is the primary damage from the actual accident or trauma itself. And then there are the secondary effects when the swelling and the edema and the increased intracranial pressure from the primary injury impacts and does secondary damage to tissues that were not initially impacted by the original trauma. We can have open versus closed TBIs. So an open TBI would be where the skull and the scalp have been opened up, and now there's the ability of bacteria or debris to get into the brain and the meninges and cause infections, versus closed TBIs where everything is intact, but everything is moved and shifted around and there's been damage by that. And what will happen is you end up with edema and swelling, which is what happens whenever you have damage or an injury to anywhere in your body. That increases your intracranial pressure, it decreases your oxygenation, it increases your CO2, so you get hypercapnia, and your blood pressure begins to drop. So these are very significant, and there's various levels and types of traumatic brain injuries. Now this picture talks about some of the skull fractures and types of problems that can occur. So the same terminology that you learned back in Nursing 200 with the types of fractures that were talked about there: comminuted, linear, open, depressed, that sort of thing. And one of the things that they love to talk about in the NCLEX is something called a basilar skull fracture. So there's some very significant, obvious signs that will happen when the patient has experienced a basilar skull fracture. One of them is periorbital edema and ecchymosis, or raccoon eyes. Rhinorrhea, where CSF, cerebrospinal fluid, is leaking from the nose. Otorrhea, where CSF and blood are leaking from the ear. Something called post-auricular ecchymosis, or Battle's sign, where there's bruising behind the ear. And hemotympanum, where you look into the ear and you can see blood visible behind the tympanic membrane. These are the classic signs of basilar skull fractures. And one of the ways that you can detect if it's CSF rather than just mucus that might be coming out of the nose is that you'll catch it on a dressing. You'll look for the halo sign, or you can test it with a glucose urine test strip. So you're going to be assessing for CSF leaks. Tell them not to blow their nose. Don't cough. All of that can cause further leakage of CSF. Don't try to clean their nose, suction out of that. Don't try to clean the ear. If there is drainage, we just want to cover it with a dry, sterile dressing. There are various types of closed head injuries. Box 45-4 talks about the types of things that we need to be teaching our patients and assessing when a patient has a concussion or suspected concussion. We can have a brain contusion, and that is characterized by something called the coup contra coup phenomenon. This means that you not only are going to have damage, say, on the side of the head where you were hit with a baseball bat, but then your brain is going to move and slam up against the other side of the skull, and that is the contra coup. So you end up having damage on both sides of your brain, or front to back. So we have to be looking for deficits that can develop after the initial injury that indicate this coup contra coup phenomenon. And then we have the worst of the problems, and that's diffuse axonal injury, where the white matter of the brain is torn or sheared in various areas, and there's significant damage to that. Patients immediately become comatose. They develop edema, cerebral edema. There's posturing, which we're going to talk about in a little bit. And most don't have any kind of long-term good prognosis after a diffuse axonal injury. There are two types of cerebral hemorrhages that we're going to talk about: the epidural, above the dura, and the subdural, below the dura. So the diagram here is kind of showing you where you would see the subdural. This is kind of cut off in Canvas Studio, but here's the epidural up here. The subdural would be here below the dural membrane. The epidural is arterial, so it is a very rapid bleed. Patients will oftentimes have a momentary loss of consciousness, and then they awaken and they have a very lucid period of time, but they will deteriorate very quickly depending on how rapid that arterial bleed is happening. So it can progress very, very rapidly. So usually patients are able to survive an injury like this because the deficits are very obvious and they get treatment very quickly. The subdural hematoma is a venous bleed, so we know the veins bleed a lot more slowly than the arteries, and this actually has a higher mortality rate because the neurologic changes are so subtle because it's such a slow bleed that oftentimes the patient has a massive area of clotting and bleeding before we actually determine that they have some neurologic deficits, and so it can be fatal. So a way to look at that, and I kind of refer to the epidural bleed as the Natasha Richardson injury. Natasha Richardson was an actress that was married to Liam Neeson. She fell while she was skiing, didn't hit her head, didn't hit a tree or anything like that. She sat up, said, "Oh, I'm feeling okay, but I'm done for the day. I'm going to go back and lay down and just kind of hang out until everybody's done skiing." By the time they got back to her room, she was comatose and eventually was brain dead and died from her injury because she was by herself and nobody noticed that she was deteriorating very quickly. The subdural hematoma I refer to as Granny fell down and hit her head and didn't want to tell anybody about it because she didn't want to go to the emergency room and then get sent to a nursing home, so she doesn't tell anybody. And it's a very slow bleed, and it's Granny, and she's getting older, and maybe she's losing a little bit of her memory, and people just say, "Oh, she's just getting older." And then one day the family arrives, and they find her laying on the floor unconscious, and they rush her to the hospital. It turns out she's had a massive subdural hematoma and doesn't survive the surgery that is needed to remove that hematoma. I'm going to talk to this concept here, minimally conscious state. Nothing that I'm going to test you on, but it's very, very interesting, and there is a video on Netflix, and also you can Google it on YouTube. It's called The Real Sleeping Beauty, and that in many, many cases what they have found that about 40% of patients that they originally thought were in persistent vegetative state, in other words, awake but not responsive, were actually what were called minimally conscious, where they had periods of vigilance and awareness and could possibly return to full awareness. So what they are doing now with patients to determine if they are in that minimally conscious is that they can do EEGs, they can do PET scans, and while speaking to that patient, ask them questions and see if there are changes in their EEG or in their PET scan that indicates brain activity. So this is a fascinating video. It's not a very long one, maybe about an hour. Really shows a girl who was hit by a hit-and-run driver, was in a what they thought persistent vegetative state for many years, and then one day just woke up. Of course, ended up with many, many neurologic deficits related to the fact that she was unconscious and bedbound for all that period of time. But a very interesting concept. Now, with brain injuries and with some of our other neurologic conditions, we can have problems with increased intracranial pressure. So you remember from anatomy and physiology, you've got the ventricles in your brain that produce CSF. So sometimes there can be a blockage of adequate drainage. So hydrocephalus, for example, that increases the intracranial pressure. Certain neurologic injuries like TBIs or strokes or brain surgeries or brain tumors can increase intracranial pressure. So one of the classic signs of increased intracranial pressure is something called papilledema, which you may also hear referred to as choked disc, and it is a swelling of the optic disc that happens with increased intracranial pressure. You will see a change in vital signs referred to as Cushing's triad. So there are 3 changes in the patient's vital sign that if you see these trends happening, then that means that the patient's ICP is increasing. Severe hypertension with widening pulse pressure, which means that the systolic keeps going up and up and up and up, while the diastolic maybe stays pretty stable. Maybe high, but it doesn't keep moving in tandem with this systolic. So severe hypertension with widening pulse pressure is one element. Bradycardia and bradypnea. We're also going to see changes in level of consciousness, behavior, changes in speech. So that's where our baseline documentation is going to be so important to detect those subtle changes that could indicate increasing intracranial pressure. Certainly increased or onset of seizures, headaches, nausea, vomiting. Those would be later stages, serious stages of increased ICP. Changes in our pupil response. So again, good documentation about what's happening with those pupils. One of them may be sluggish, the other not. And changes in the shape of the pupil, very serious. If they're no longer round and they become oval, very severe. And then abnormal posturing. So there's a couple of different types of posturing that you do need to know. And my suggestion is you learn one of them really well and that be able to describe that so that if the other one is described or you see that clinically, you'll know it's the other one. So the first one is something called decorticate posturing. And I kind of like this because it is kind of easy to remember. Decorticate, referring to the cerebral cortex, and it's abnormal flexion toward the core of the body. So the upper extremities are what you're going to be looking at when you look at posturing. Everything's going to be stiff. The legs are going to be stiff. The feet might be internally rotated. But with decorticate posturing, you have abnormal flexion of the arms toward the core of the body. And it indicates damage to the cerebral cortex, decorticate. Decerebrate is where, again, everything is stiffened, but you have abnormal extension away from the body. So the arms are abnormally extended away from the body. The legs are still stiffened, maybe internally rotated. That's decerebrate posturing, indicating damage to the cerebrum or the brainstem. So learn these, learn one of them really well, and that's probably going to help you remember it, rather than trying to memorize each one. To manage increased intracranial pressure, mechanical ventilation. Hypoxia and hypercapnia are very serious problems for that patient with increased intracranial pressure, because the higher the CO2, the worse the pressure becomes. So we need to get them well oxygenated and lower their CO2 levels. We're going to do various monitoring devices. We're going to do a ventriculostomy, so an opening into the ventricles, and put in a monitor that can measure the pressure. And we can also, that can also double as an external ventricular drain to drain the excess CSF that's causing the increased ICP. And then we can have a craniotomy, where we actually open up the skull, remove a segment of the skull. It's called a decompressive craniotomy, which allows the brain to herniate out as it swells and swells and swells. And then as they respond to treatment, then it will shrink down and go back inside the brain, inside the skull, and then we can put that piece of skull back on there. While we're waiting for that to happen, frequently the piece of skull is put into the patient's subcutaneous tissue in their abdomen to keep it moist. It can also be frozen or stored in saline. Our pharmacology for increased intracranial pressure is to prevent and treat pituitary dysfunction, because all of that swelling can put pressure on the pituitary gland, which we know is the master gland, and it can impact so many other parts of our body. Glucocorticoids, such as dexamethasone or methylprednisolone, to decrease cerebral edema. Diuretics, specifically osmotic diuretics, such as mannitol, which pulls that excess fluid out of the brain cells and helps to diurese it. It works better for cerebral edema than if you were to give a loop diuretic such as Lasix. We need to keep the body temperature normal so that it doesn't require and use up a lot of oxygen and energy. And we need to prevent seizures, because again, we don't want to cause any undue stress to the brain and cause the intracranial pressure to go even higher.